Still 6:29, isn't it?
Okay. We'll wait another moment. Thank you. Very good. We have approximately 40 people participating, so we can start. It's also 6:30 Pacific time. My name is Dean Owen. I head up communications for the Institute for Health Metrics and Evaluation at the University of Washington School of Medicine. Thank you all for joining today for the pre-launch briefing for the press on the 2019 Global Burden of Disease Study. We are honored today to have the following speakers: Dr. Richard Horton, the editor-in-chief of the Lancet; Dr. Emmanuela Gakidou, professor at the Institute for Health Metrics and Evaluation; and Dr. Christopher Murray, the director of the Institute for Health Metrics and Evaluation. My name is Dean Owen, and I'll be moderating our session today. Each of the speakers will open up with approximately 10 minutes each of their remarks, their observations, their insights about the global burden of disease, and then we will open up for questions. Any journalists who want to ask questions, please post those questions in the chat function directed only to me, the moderator, Dean Owen, along with your name, please, and the name of your news organization that you represent. Please also be reminded that all the information you hear today about the Global Burden of Disease study is embargoed until the actual release of the study, which will be Thursday, the 15th of October at 6:30 p.m. Eastern Time, US. That's 11:30 p.m. in London. Again, thank you for joining today, and I'm going to turn it over to Dr. Richard Horton, the editor-in-chief of the Lancet. Dr. Horton, the floor is yours.
Thank you very much, Dean, and welcome everybody. We meet at a moment of global emergency, and one lesson of this pandemic is that it is not a simple pandemic. In fact, it's a synthesis of at least two epidemics, a coronavirus and an epidemic of non-communicable diseases on a background of poverty and inequality. What we're facing is a syndemic. And this means that when one talks about how prepared we were for COVID-19, we need to talk not only about the preparedness for a virus, but also about how healthy our population was to withstand the impact of that virus. The more risk factors in our communities for COVID-19 that a country has, the more chronic disease, the more inequality, the less healthy a population is, the more vulnerable that country will be to COVID-19. What you're going to hear about today, the global burden of disease, is the most comprehensive analysis of the state of the world's preparedness for COVID-19 immediately before the virus hit us. It reveals that the world was acutely vulnerable to a virus that targets older citizens, those living with chronic non-communicable diseases, and those living in societies with pervasive inequalities. The global burden of disease shows the scale of the challenge that COVID-19 presents us. If we are truly to protect our communities from the ravages of this coronavirus, governments must devise national strategies, not only to reduce the prevalence of the virus, but also to more assertively address the burden of chronic disease and the risk factors for chronic disease. And you're going to hear much more about that now. So I hand back to Dean. Thank you.
Thank you, Dr. Horton. Just as a reminder as well, if any journalists want to record today's session, please feel free to contact Christina Culpepper in the chat for authorization to do so. And again, any journalists wanting to ask questions, please feel free to post them in the chat area. Again, only to me, the moderator, Dean Owen. Thank you, Dr. Horton. I'm now honored to introduce Dr. Emmanuela Gakidou, Professor at the Institute for Health Metrics and Evaluation. Dr. Gakidou, the floor is yours. Thank you.
Thank you, Dean, and thank you, Richard, for setting the context in which the Global Burden of Disease 2019 results are being released. I'm going to share a bit more detail about some of the key findings from our study. But before I start, I wanted to mention that the Global Burden of Disease is a very large scientific collaboration. It quite possibly is the largest global scientific collaboration. And the study that is being released tomorrow represents the work of over 5,500 scientists and researchers from around the world. We are very grateful for all their contributions, and I'm very honored to be here today representing this work. I've seen that a few of our collaborators have joined today's session, and I wanted to just mention that we're very privileged to be working with such a distinguished group of researchers from around the world, and it makes this the most comprehensive and democratic global study on health in the world. For those of you that may not be familiar with the global burden of disease, we study what causes death and disease around the world. More specifically, we look at about 300 causes of death, about 370 diseases and injuries, if you count everything, and 87 risk factors for health. We provide measurements for 204 countries and territories and for every single year between 1990 and the present. And we look at all ages. We have 23 different age groups. So because we measure everything using the same framework, the estimates we produce in the Global Burden of Disease study are comparable, and they can be used to answer questions like, is heart disease, depression, or low back pain a greater health problem in my country? As it is a comprehensive source of information on the state of health around the world, the Global Burden of Disease study produces a lot of data and can answer a lot of questions. If I were to try and summarize some of the key findings today, I would say that one of the most important messages from the Global Burden of Disease 2019 is that over the past decade, the world has done a poor job of reducing harmful risks, and this is fueling a global chronic disease crisis. So while communicable diseases are causing less illness, disability, and death than in the past, with the obvious exception of COVID-19, chronic diseases are on the rise. And the good news is that we find that there is huge potential to improve health by reducing risks to health. This year of all years has been a very clear demonstration that all societies play a very high value on health. And with the data provided by our study, countries can make decisions that can save lives and improve the health of populations around the world. What the GBD 2019 study reveals is some very disturbing trends over the past decade in several high preventable risk factors, and these include obesity, high blood sugar, high blood pressure, and also factors like air pollution, alcohol use, and drug use. And these are contributing to the growing burden of non-communicable diseases on which COVID-19 has posed its toll. The greatest cumulative impact on health comes from a very large increase observed in the last decade in metabolic risks. Collectively, we find that metabolic risks accounted for about 20% of total health loss worldwide in 2019. And this is twice as much as it was in 1990. So over the course of 3 decades, metabolic risks have increased and significance in terms of their contribution to health loss worldwide hugely. And this growing exposure to metabolic risks, combined with rising cardiovascular disease in many places, is a clear indication that the world may be well approaching a turning point in life expectancy. So after decades of increasing life expectancy, we may be reaching a turning point. There are some risk factors that have declined over the past decade, and among the major risks for non-communicable diseases, the only one that has declined substantially is smoking. And this is likely due to a lot of major efforts to implement international tobacco control policies. We also have seen some large declines among risks that are strongly linked to social and economic development. And these have contributed to significant reductions in global child death rates. So the risks that have declined include household air pollution, unsafe water sanitation and hand washing, and stunting. Of course, the impact of risk factor varies widely across regions, but we see in much of the Americas, both North America and Latin America, in Asia and in Europe, we see a very high toll of high blood pressure, high blood sugar, obesity, and tobacco use. While on the other hand, in a region like Sub-Saharan Africa, the leading risk factors include malnutrition, unsafe water and sanitation, and hand washing, and air pollution. So I would like to just end by saying that health loss and death from most of these risk factors is preventable and avoidable. These risk factors can be addressed successfully. And by taking action now, individually and collectively, we can dramatically and sustainably improve the health for generations to come. And with that, I'll pass it back to you, Dean. Thank you very much.
Thank you very much, Dr. Gakidou. It's now my pleasure to introduce the Director of the Institute for Health Metrics and Evaluation, Dr. Christopher Murray. Dr. Murray, the floor is yours.
Thanks, Dean. And I'll add some comments on the findings from GBD 2019. So first is to start with the generally good news that over the last 2 decades particularly, there's been real progress in improving life expectancy and healthy life expectancy. And most importantly, there has been more progress for the worst off countries in terms of health than the better off countries. And so that catch up is narrowing the gaps between the bottom quintile of nations in terms of development and the top quintile. And that, as we dig into what's driving that progress, an important part of that is programs that were funded in targeting maternal and child health and HIV, TB, and malaria. But also, and probably most importantly, it's because education of girls in particular and income per capita was rising. And so this general level of development in the bottom quintile was actually faster than in the top quintile. So we need to remember that health is in the context of these broader development determinants. And so while COVID and all the events that have unfolded this year point to the importance of health systems, we also need to recognize that general factors such as the education of girls are particularly important in understanding what's happened in the last 2 decades. Now, when in the GBD 2019, we have also taken the large database that we have on both health outcomes, but also health systems to try to understand the role of health systems in some of these trends, both in terms of the progress, but also in the threat of rising NCDs, and particularly those risk factors that Dr. Gakidou mentioned. But when we, in this issue of the Lancet is an analysis around universal health coverage, And when we look at how health systems have been able to respond to the challenge of NCDs, and I think this also extends to understanding how they've responded to COVID, we see that there is a particular challenge in the speed or flexibility with which systems respond to changes in the disease profile. So in particular, where a whole host of countries in the middle quintiles of development around the world, they are slow to respond to this shift towards non-communicable diseases and slow to respond to the shift towards the risk factors, obesity, air pollution, foremost amongst them. They're also slow in terms of the coverage of their interventions to respond to the shift towards more disabling conditions. So in addition to the shift towards NCDs, the rising numbers of non-communicable diseases, that shift in risk factors, we're also seeing a shift around the world towards more burden of disease from conditions that cause disability as opposed to death. It turns out in the era of COVID that many of those conditions are also things that increase the risk of COVID death. So that shift towards disability is also a shift towards vulnerability. And our health systems around the world, in terms of the programs they fund, the coverage of their interventions, are often dealing with the challenges of a generation ago and are slow, as we've demonstrated in this study, to increase coverage for those particular programs. So I think what's interesting about the GBD as we expand over time is giving us a lens on both the health patterns around the world in all their complexity and the way systems are responding. The other part that's in this issue of the Lancet that's part of the GBD analysis is a forward-looking view of how population age structure is shifting and how we are seeing a more rapid transition to older populations in at least half the countries of the world. And again, that creates a much larger group of people that are particularly vulnerable, as we've seen during the era of COVID. And those core demographic challenges are a key part of the health trends that we observe around the world. A few comments on the new format for GBD 2019 that's in these in the Lancet issue. For major diseases and risk factors, there is 2 pages in this in the Lancet issue that summarize all the key information for those diseases and those risk factors. But is the which countries have the most, what's the global number of deaths and the incidence and prevalence of those conditions. So it is bringing together information in one place for each disease and risk in we think a unique way to aid in somebody who's interested in a particular disease or risk factor. I think we've also learned how critical during the course of COVID that timely information is. And so I think the fact that the GBD provides this resource where we have brought together all the publicly available and often data that is shared to the study from different governments in one place is a super important resource for thinking about priorities in each country. And then lastly, a comment on the formal launch, which will be tomorrow. We will have, because we have a close collaboration with the World Health Organization, Dr. Tedros and one of the Assistant Directors General, Samir Asma, at the World Congress on Public Health at the launch tomorrow, talking about some of the key messages from the GBD as well. So I just wanted to highlight that this work, in addition to being an enormous collaboration around the world, is done in close collaboration with WHO. Over to you, Dean.
Thank you, Dr. Murray. And on the screen, as you can all see, are some of the key points from the Global Burden of Disease study. We have our first question from Janelle Miller from Helio. In fact, she has 3 questions, and I'd like to send or ask each of you to address one of them. The first is for Dr. Gakidou. What are the most disturbing trends in the United States that you found in this edition of the Global Burden of Disease? Dr. Gakidou?
Thank you, Dean, and thank you, Janelle, for the question. The trends in the United States are quite disturbing for many of the risk factors that I mentioned are important around the world. Specifically, obesity is a very high risk factor in the US and has been getting worse over the past couple of decades, but also high blood sugar and high blood pressure are very important risk factors. I don't know if Chris, you would like to add on the disease front, something about the diseases that these risk factors contribute to and the trend in life expectancy.
So life expectancy in the US has stopped increasing, as I'm sure you're aware. And as we look at diseases in the United States, there is a clear rise in the last, even before COVID, in terms of diabetes, suicide, and we're seeing some increases in mental health conditions, and a very large increase in drug use, drug dependence deaths. And so that combination has led to the slowdown and sort of stagnation and improvements in life expectancy.
Thank you. The second question, Dr. Murray, I would like to refer to you from Janelle Miller. How can physicians reverse these negative trends?
Thank you for the question. I think that because some of these core risk factors, such as obesity, blood pressure, blood sugar, still, despite progress, tobacco use, are such a critical factor. Those risk factors, there are social and contextual determinants. But I think physicians have a role to play in helping their patients identify what are the big opportunities for improving their patients' health through modifying some of those risk factors. And we know even within the US, as an example, that a very large fraction of the variation in life expectancy across counties can be explained by the big 5 risk factors that we've been talking about. So any help that physicians can give to their patients in managing those risks, and that includes pharmaceutical management, for example, of blood pressure as one example.
Thank you, Dr. Murray. And Dr. Horton, the last of Janelle Miller's questions is for you. How does or does not this report underscore the need for social determinants of health-related screenings?
Thanks very much indeed. I think when you look at the correlation and association between health and what the report goes into in some detail, in one of the papers in particular, this measure called the socio-demographic index, then what you're seeing is the linkage between education, economic growth, and in particular gender equality and the contributions they make in creating health. If we think about health as something that society creates, we do tend to focus on the health system. But what the global burden of disease shows so precisely is the contribution of other sectors of our society to the idea of creating health. So as much as we should focus on issues in the health system, obviously for acute care, for example, the fact is that those countries that have invested in their education, that have successful economic growth, and who take the participation of women in society seriously as a social objective, those countries are creating health by investing in those determinants. So I would say that's an extremely important lesson from the GBD. Another lesson I would also say in the context of non-communicable diseases is the importance of commercial determinants of health and the way that the market creates conditions that often lead to adverse health outcomes. And that's especially the case when one's thinking about obesity, because one of the major drivers of the obesity epidemic we're facing, which is proving so resistant to intervention, is the fact that we have a commercial environment that fosters food choices which drive the obesity epidemic.
Thank you, Dr. Horton. The next question, pardon me, the next question comes from Javier Aja from Spain's news agency, EFE. My question is in relation to life expectancy. The study, quote, reveals that the rise in exposure to key risk factors, including high blood pressure, high blood sugar, high body mass index, and elevated cholesterol, combined with rising deaths from cardiovascular disease in some countries, such as the USA and the Caribbean, suggest the world might be approaching a turning point in life expectancy gains. And his question is, does that mean that I assume that life expectancy, does that mean that it will stop improving, or will it recede? I'll ask Dr. Murray to take that one on first, and maybe also as well ask Dr. Gakidou or Dr. Horton. So Dr. Murray, could you please take a first stab at that answer? Thank you.
So for the first time, we have seen that the cardiovascular disease in a number of countries, not just the US, has actually stopped declining. And there are some countries where it has actually increased in the last few years. And what we think that is driving that is that the obesity epidemic, the increases in blood pressure and blood sugar, probably fueled by obesity, has been enough to overwhelm whatever further progress there was in the other management of cardiovascular disease. Cardiovascular disease being such a large component of mortality in high-income countries, that's enough to actually combine with the rise of diabetes and with some of these adverse trends in suicide and drug use, that's enough to have stopped life expectancy improving. So that's where the threat lies. It's not that we expect life expectancy to reverse in low or middle income countries. It's really a phenomenon in high income countries. And it just speaks to that we do seem to be at a turning point in the high income world, where if we don't manage these risk factors in a more sort of proactive way, we will end up potentially with no further progress and quite possibly reversals in life expectancies. But I think the main thing that we're observing is sort of the stop of the steady improvement that we've become used to as sort of going to happen each year in the high income world.
Thank you, Dr. Gakidou or Dr. Horton. Would either of you like to elaborate on Dr. Murray's comments?
No, I'm fine, thank you.
Okay. Pardon me. Next, for Dr. Gakidou, is it right to regard the metabolic risks that you highlighted as a silent pandemic and possibly even bigger than COVID-19?
Thank you. I would say that it's not really silent. It is a very large contributor to health loss around the world. So what we see is that collectively the metabolic risks account for about a fifth. So about 20% of all health loss is attributable to these metabolic risks. So I think it's speaking to us very loudly. It's not really silent. And the good news is that a lot of these are preventable risk factors. There are things we can do to avoid this health loss, both death and disability, that are caused by these metabolic risk factors. It is one of the key messages in our study how much the contribution of metabolic risk factors towards overall health loss has risen in the past couple of decades, 2-3 decades. And it is important to recognize it and address it from the individual level, the community level, and the government level.
Thank you. The next question is from Sarah Bosley from The Guardian. Is the COVID-19 pandemic likely to make a difference to the trends of deaths? Will it change trajectories significantly because this is an infectious disease, even though it is so much worsened by the prevailing NCDs? I'll ask Dr. Murray to take a stab first at that answer, and then offer as well the opportunity for either of our two speakers to comment as well. Dr. Murray?
So we expect that the effects of COVID are going to be felt not just this year, but a number of years into the future, and that we will see a quite considerable impact through a number of mechanisms, which I'll outline. So first, we will have a substantial large number of deaths. We already have. We expect more with the surge coming in the fall and winter in the Northern Hemisphere. This year, we expect COVID to continue to have its direct effects in 2021 and for those to be quite considerable. We know that COVID has had an effect on the delivery of key interventions. So we know, for example, that childhood vaccination rates are depressed in a number of places in the low-income world because of the social distancing mandates and fears of people coming in contact with the health services. We also know that the social distancing mandates have led to fewer women giving birth in facilities, reluctance to go to health facilities for needed NCD care. So we also expect those effects to show up for 2020 and 2021. We also expect that the economic consequences of the effects of COVID to affect economic growth, increased poverty, which will have direct effects on health as well. And those will be much longer lasting. So as we've tried to analyze this, we expect the effects of COVID to last for a number of years, well into, if you look at the economic effects alone, they will be affecting health out for 3 or 4 years and potentially right through the SDG period. And some of those analyses were actually in this year's Goalkeepers report from the Bill and Melinda Gates Foundation, which drew heavily upon the GBD for that analysis.
Thank you, Dr. Murray. Dr. Horton, given your book, COVID Catastrophe, published earlier this year, do you want to also add anything to Dr. Murray's comments on Sarah Bosley's question?
Thanks, Dean. Well, actually, Sarah, one of the things that is very interesting, and this is a bit of a UK answer, but if you look at the data on life expectancy in the UK, it's disaggregated by region very helpfully. And if you look at where life expectancy is lowest, you'll see that that aggregates in the Northwest, the Northeast, Yorkshire and Humberside. And that's very interesting because I don't think it's a coincidence that we're seeing some of the most serious effects of COVID-19 in some of the areas of the United Kingdom where there are the lowest life expectancies. And if you take life expectancy as a marker for overall health status, then what you're seeing is that in parts of the United Kingdom with some of the most challenging health profiles, those are the populations that are most vulnerable to COVID-19. So this is really where I want to really emphasize this point that we are not dealing with a pandemic. We are dealing with a syndemic. It is the interaction of a virus with people living with other diseases that is the challenge that we face, especially when you factor in the social gradient issue. So I think governments, if they do not address the fact that this is a syndemic and they focus only on trying to reduce the prevalence of a virus, this is a strategy that in the long term will fail. We need a comprehensive approach to this syndemic. And the reason why you're seeing the Northwest and the Northeast and Yorkshire and Humberside so badly affected is because they are the most vulnerable populations, and the GBD anatomizes that really very, very clearly.
Thank you, Dr. Horton. Our next question is from Deanne Septieri from the Jakarta Post. I want to ask a question to the panel to elaborate more on the regional trend, specifically Southeast Asia and Indonesia, in comparison to other regions. I'm going to assume the question deals with the findings from the global burden of disease. So Dr. Murray, would you like to start with that, start in addressing that question, please?
Sorry, Dean, you just cut out briefly on Zoom. So could you repeat the question
Sure.
from Indonesia?
I want to ask a question to the panel to elaborate more on regional trends, specifically the Southeast Asia and Indonesia in comparison to other regions around the world.
Yes, and I just wanted to highlight in trying to answer that, of course, the papers in the Lancet have a tremendous amount of detail by country and by region, but there's also, with the release on Thursday, and I don't know, Dean, how we're making this available to the media in advance, the online tools give you access to results by country. So there's a lot of rich material there by country. So for Southeast Asia, this is a little bit from memory. The progress has been quite considerable on life expectancy and healthy life expectancy over the last 2 decades. But some of the NCD risks are particularly prominent. For example, tobacco use is a very high risk factor in the region. This will be familiar to you in Indonesia with some of the highest tobacco consumption in the world. And those are certainly part of what we're seeing. So I think the basic message around NCD risks is particularly relevant to the region, as well as the message around environmental risks, including air pollution.
I mean, I'm just looking up the data on Indonesia and the contribution, for example, of total health loss to non-communicable diseases between 1990 and 2019. In 1990, non-communicable diseases contributed about 40% of total health loss. That had more than doubled by 2019 to 82%. So Indonesia, according to the global burden of disease, is in the grip, right in the center of the storm that Em described so clearly.
Thank you. The reporter has a second question. We often hear how most of COVID-19 deaths were due to pre-existing conditions, which are something governments used to justify the poor handling in curbing the spread of the virus. Can any or all of you please comment on this and whether this is a fair assessment? Would someone like to start?
I can start. So if you look at risk factors like obesity, they are quite high in New Zealand and Australia, but there's almost no deaths in New Zealand and Australia. So as Dr. Horton has said, it's the combination bad control of the virus at the beginning and the presence of those risk factors. The presence of those risk factors clearly does, like obesity, high blood pressure, the general comorbidity, increased risk, is not mean you're going to have a large epidemic, as is demonstrated by a number of countries that managed well the early phases of the epidemic and have managed through sort of classic, case detection, contact tracing strategies and transmission control to avoid widespread transmission in the community.
Anyone else like to elaborate on what Dr. Murray said?
I mean, I would just add that it is the combination. It is, if once you've let the virus into your society and once it's widely prevalent, then if you have a background of poor health in the community, then that community is at risk, which is why it's so important to suppress the prevalence of the virus. Now, there's a lot of debate about, the Great Barrington Declaration. There's a lot of debate about focused protection and allowing the virus to circulate in communities and just protect those who are at risk. What the GBD shows that in many, many countries, the number of people at risk is far greater than one imagines. Again, if I take the United Kingdom as an example, there was something like 2.5 million people shielded during the lockdown of wave 1. But actually, if you look at the people who were truly at risk, so people who were over 70 and people under 70 living with a chronic disease, the figure is much, much higher for the UK, over 8 million people. So I think that it's these interactions that are so important to understand.
Thank you. Our next question is also from a different journalist, also from the Jakarta Post, Ardila Sakraya. My question to the speakers would be on how low and middle income nations, including Indonesia, can make sure that despite the pandemic, governments and healthcare systems can still provide prompt actions and treatments to NCDs, patients, and others with risk factors while also keeping them safe. I presume safe from transmission of the virus. Dr. Murray, would you like to start on that one?
Sure. The interesting thing is, one of the drivers behind the concern about reduced care for NCDs during the pandemic is people's understandable fear of transmission of the virus if they go and have contact with health services. And the good news there is that in those health systems where there is adequate provision of personal protective equipment for healthcare providers, it turns out that healthcare providers have no higher rate of COVID than the general public, meaning that when you have adequate supplies of PPE, the health services can actually be quite safe. And in fact, in some places, the prevalence amongst healthcare workers is lower than in the general public because they take greater precautions. And so that, and there's actually quite a rich data source around this. The weekly, or actually the daily Facebook symptom survey, which asks in some cases about occupation and about whether you've been diagnosed with COVID, gives us some insight in different countries. Now, in some countries, adequate PPE is not available. And so that does generate a real risk there. But it is possible for health systems to make sure their health care workers are well protected, and then that will build confidence and trust, we hope, in the general public of those with NCDs who need care.
Thank you. Would either of our two speakers like to comment further on answering that question?
Well, I just want to draw attention, I'm not going to go into any detail now, but if the journalist looks at figure 4 of the Universal Health Coverage paper, in this collection, then you will find the specific data for Indonesia on what's called effective coverage for universal health coverage. And that is disaggregated for different categories of treatment. And you'll be able to see there's an assessment of how well that country, in this case Indonesia, performs for each of those disaggregated elements in this universal health coverage index. So that will give you a background measure of country performance in those selected areas. And then, of course, it's as Chris says, you then got to factor in the effect of the pandemic on top of that. But the baseline data for Indonesia are very clearly set out. Figure 4, universal health coverage paper.
Thank you, Dr. Horton. The next question is for you. Your notion of a syndemic suggests that preventing outbreaks like COVID-19 are incredibly complex. What concrete actions can and should governments or individuals be doing?
Well, that's right. They are complex. And I think the way we've debated the pandemic, inevitably, because it's a new virus and we've been hit with it very hard in many countries, is we become very, very focused on the virus. But I'd like to, if we just lift our gaze and think about how we protect our communities in the future, it is about pandemic preparedness in the sort of traditional sense, but it is about seeing the health of our population as a dimension of our national security. I mean, we've seen the economies in countries absolutely crash thanks to this pandemic. And the shadow, if we talk about a shadow pandemic, the shadow of this episode is going to live with the next generation for not just years to come, but decades to come. I mean, we're really in danger of losing a generation of young people who have been shut out of their schools. Over 1 billion school children are not able to go to school at the moment, shut out of their schools, not working in ideal conditions at colleges and universities. So the way we protect the health of our people is not just a health issue. It's not a narrow sectoral issue. It's actually about our national security. So if we think about health as part of our homeland security, then that makes investment in health and investment in the determinants that shape health a much more important dimension of our policy making for the future. And I think that an absolute key issue underlying that is the notion of equity. Societies that are deeply unequal, societies that tolerate the kind of disparities that we see in many countries today are societies that are extraordinarily brittle. And one of the lessons of this pandemic is the brittleness of our societies, which many of us have been surprised by. But when you actually look at the fabric of our society, we shouldn't be surprised. When the gap between the richest and the poorest is as great as it is, that society can easily crack when it's tested and put under pressure. And that is what we have seen in many of our countries today.
Thank you, Dr. Horton. Our next question deals with how and should governments address certain issues. It's been 56 years since the United States Surgeon General's report linking smoking and tobacco use to cancer. 56 years later, governments and the actions taken by governments, such as taxation, raising or the age appropriate for smoking, have indeed lowered the use of tobacco around the world in most countries, not all, but most. What about obesity? Is there a similar strategy that governments could take in order to reduce this growing health problem? I actually would like all three of you to comment on this one, and I'll start with Dr. Murray.
The challenge of obesity finding effective strategies akin to what is being, where governments have the will, have been very successful on tobacco, remains a big issue. At some level, we know it's about what people eat and about how much physical activity they have. But the number of, even at the local level, successful efforts are quite limited. So in other words, when we look around the world, we don't actually see any success stories of people countries or communities bringing down obesity. We see places with slow or no increases in obesity, but nobody that's actually turned the tide on obesity yet. So we're in a territory where we don't have a success story to point to, but on the, if you look at some of the individual level interventions, like the diabetes prevention trial in the US, which you did demonstrate that at the individual level, with concerted efforts around both diet and physical activity, individuals can lower weight. It does suggest that there are strategies that could be tried, and that's sort of where we are now in terms of trying to go out and test the community level strategies that will reduce food intake, particularly those foods that cause obesity or are more likely to cause obesity, like sugar sweetened beverages, as well as efforts to increase physical activity. So it's less clear, at least to my mind, of the policy package to recommend, but the urgency of the challenge means that communities need to be trying various strategies, and then we need to try to evaluate those and hopefully identify success models.
Thank you. Dr. Gakidou, any additional comments, especially given your expertise in the area of tobacco?
Yes, thank you, Dean. And I think tobacco control provides some good lessons learned that could be used in other risk factors. I think the one thing that we know is that just providing information does not work. So what will not be effective is just giving the general public information about what is good for their health. That has not worked for tobacco. What we have seen work is some combination of regulation, taxation, and subsidies. As Chris mentioned, there haven't been successful examples for obesity or some of the other risk factors that are on the rise, but there also have not been concerted efforts from governments at the national or the global level, and that is something that potentially could be beneficial. There has been much less attention at the policymaker level of how big of a problem this is and how in need of a solution to reverse the trends societies are. I think it will entail individual action, community action, as well as policy at the national and the global level. And I think tobacco control provides a good starting point for policies to be formulated for other risk factors such as obesity and physical activity and diet.
Dr. Horton, any additional insights or observations on that one?
Well, I think I'd only say that I think we've completely misunderstood what obesity is. I think that many health practitioners and certainly all governments see obesity as an issue of lifestyle, that it's something to do with our choices that we make. Actually, obesity is a disease. And the fact that we don't frame obesity as a disease means that we don't take it seriously. I think if we saw obesity as a metabolic disease, which is as insidious as any other kind of disease, whether you were talking about cancer or cardiovascular disease, then I think we would take obesity much more seriously. But the fact that we label it a lifestyle choice means that we dismiss it. Obesity is a very, very serious disease that needs to be tackled just as any other disease. And that's something that we as health professionals should be much stronger in advocating to policymakers.
Thank you. We have time for one last question and a reminder from me to reiterate that the 2019 GBD study does not cover COVID directly, but obviously there are issues and trends in what we're seeing in the GBD that affect COVID. And I think this last one is for Dr. Murray. When will the GBD 2020 be released? And can you give us any insights as to how COVID will affect that GBD 2020 and any potential findings that you might be able to share? Again, this is early, but obviously lots of journalists are clearly very, very interested.
So clearly a major focus for us on GBD 2020 will be trying to get the best possible assessment of the full impacts of COVID, both directly on other causes, the mental health impacts, the impacts through deferred care, reduced immunization. So the total effects of COVID. And so that's a heavy emphasis in what we are currently working on for GBD 2020. I think the question of when it will be released, it's an excellent reminder to point out that the GBD goes through the process of peer review. And so we are not in control of when things come out. It's very much a function of the types of issues that scientists raise as in the peer review process and how quickly we're able to address those. But sometime in 2020 it's a good bet, given the urgency around understanding the effects of COVID in 2020, since the epidemic is not going to go away in 2021. We will certainly be trying our best to get to the scientific journals, particularly the Lancet, our assessment around that in a timely way as soon as the data are finally in for the year.
Thank you, Dr. Murray. We're just at about time. I want to take this opportunity again to thank everyone who joined today for their participation. I especially want to thank our three speakers, Dr. Emmanuela Gakidou, Dr. Richard Horton, and Dr. Christopher Murray. Remind journalists that if they're interested in acquiring a video of our session today, please feel free to email the IHME Communications Office at media@healthdata.org. Again, thank you for joining today for this fascinating and engaging study and review of the Global Burden of Disease study. Again, it will be released and available on both the IHME and Lancet websites on Thursday, tomorrow, the 15th, at 6:30 p.m. Eastern Time, 11:30 p.m. London time, 3:30 in the afternoon, Seattle time. Thank you all again for your participation, our three speakers. Have a great rest of your day. Thank you.
Thank you.
Thank you.